Clinically, usually when these children have isolated single foot club foot or they have bilateral club foot, the first and foremost, usually parents come during the first week as well, and you see a neonate with bilateral club feet, or you may see them with certain typical features of the club foot as well. And why it is important to assess this club foot, because we need to assess what are the different components of it, and is it club foot or is something else, because it could be congenital vertical talus with the same, because when the parents would come to you, they will complain that the feet are actually abnormal. They will not say that this is club foot or it's something else. We can have a skew foot of the child as well. We can have isolated metatarsal adductus. We can have isolated pes Equinovarus deformity as well. Therefore, you need to assess what exactly is the component, and all the four components of club foot are present or not. And when we are dealing with the clinical features, this is what we usually see. This is the classical picture of a club foot, that the child who's probably 5, 10 or 15 days old, and the parents come to your clinic with this sort of a picture that both feet are abnormal. If you see closely, this looks like a club foot, but even in this picture you can appreciate this is much more rigid or severe as compared to this form. And you can appreciate this by crease, because the cavus of this foot is more severe than the cavus of this foot. Therefore, you need to assess very carefully, is it club foot or it's something else. And when the child would come, what would it present like? When would you examine the midfoot? Midfoot is around here. You would appreciate the first metatarsal head is going down, and you can palpate the first metatarsal head. This is due to the cavus formation which has occurred at the midfoot. Then when you assess the forefoot and you put it up from the front and look at from the front, you can appreciate, or when you slightly flex this and rotate this, you'll see that this forefoot is more medialized as compared from the central axis of the foot. That is why this means the forefoot is in adduction as well. And then when you assess it from the lateral side, you will also see this picture. Now this is a bit less severe, or now it's also showing something else as well. If you see, this could be CVT, this could be CTEV as well. That is why assessment is very important, because sometimes Equinus may not be marked, or Equinus may be and Varus may be more marked as compared to the midfoot cavus or forefoot adductus as well. So if you have to label a child with CTEV, you have to assess all the four components. Is midfoot cavus present or not? Is forefoot adductus present or not? If it's isolated forefoot adductus, probably this patient has, or this child has metatarsal adductus as compared to the CTEV. And if there is a rocker bottom deformity, this could be due to CVT as well. And if the child has associated myelomeningocele or spina bifida, then you must rule out CVT along with the CTEV. All these things have to be kept in mind, because all these abnormalities include the problems with the feet. Now if you see, this is from the front, you can see this is the axis of the foot. There is not marked adductus, but if you see it, can you appreciate this foot going downwards? This is due to the cavus at the midfoot. And if you look this foot from the lateral view, you would appreciate the Equinus as well as the Varus of the heel as well. And the heel Varus can be seen from the behind. You cannot look it from the front. You would see the calcanea will be going more towards medially displaced, and this will also be in Equinus. Like if you see this foot, you can appreciate definitely there is Equinus and Varus at the hind foot as well as the cavus, although there is no marked adductus present in the forefoot. But this all could be relative. Sometimes some degree of all the components must be present, and it's usually very rare to have a single component. For example, this is very rare to have actually cavus of the midfoot only. There is always usually associated with other components as well. And when you look at the other clinical features, then you have to assess if you are seeing this child, and you can appreciate this probably bilateral club foot, although cannot confirm on single view, because you can appreciate midfoot cavus is seen, although there is no marked adductus present. But if you see this heel is going, if you see is going towards medially, this means it is actually Varus and Equinus is present. But if you see something else is over here, if you appreciate, you can appreciate there's a tuft of hair and something which is present on the back as well, because CTEV, CVT, all these diseases are actually associated with myelodysplasia, myelomeningeal spina bifida as well. Therefore, you need to assess the child as a whole. Sometimes classical CTEV would present, sometimes it would be very difficult to differentiate whether it is congenital Talipes Equinovarus or is it congenital vertical talus or it's simply metatarsal adductus. Therefore, sometimes when the assessment becomes difficult clinically, then you can go for certain scoring systems or certain x-rays as well, and we have actually a scoring system which is available to score whether it is a CTEV or not. And that is, there are two basic scoring systems which are available. One is the Pirani scoring system, which was initially given in 70s, then has been modified a little, and there's a newer scoring system as well called as Demiglo et al. Scoring system as well. It basically measures all of those four components, but in a certain different fashion. For example, when we're talking about Pirani scoring system, is a bit system which actually easily can be done clinically. You do not need x-ray straight away to actually go for Demiglo scoring. That is why it is relatively easy. We have to, it's basically initially when it was given, it was 6 components, but now it has been a bit modified to increase into 10 components, and I will be explaining them in detail. First, you have to check the rigidity. What sort of a rigidity is this? Is it rigidity is of the Equinus? If the foot remains like this, you're trying to push it up, it's not coming down. This is called as rigid Equinus. It can come up to neutral, or it can go into 20 degree of dorsiflexion. So if the foot is going into a 20 degree of dorsiflexion, this means it's very supple foot. If it comes to neutral, it's mildly rigid. And if it stays in Equinus, whatever when you're pushing it up from the lateral side and you're looking at the foot from the lateral and trying to push it up from the toes and it's not coming up, this means it's rigid. So other is the curvature of the lateral border. As you know, the foot is going into varus, therefore there is elongation of the lateral border. So one way is that how much correction can be easily done when you bring back the toes back to the medial side or the central line of the axis of the foot. How much correction is possible on the lateral border? If it's completely correctable, this means it's almost negligible lateral border is present. If it's partially correctable or it's completely uncorrectable, that is what actually determines the score. Then third thing is the medial crease. Why medial crease is important? Because it is actually the medial crease which is causing the cavus. When the cavus happens, the head drops down. This leads to a medial crease which is seen on the, especially a single crease seen on the foot of these children, and this is called as the medial crease. When we push the head up, we see how much actually the medial crease is cleared. If it is cleared completely, this means it's very supple foot. It may be partially cleared, or it may not be cleared at all. That means it's actually a rigid cavus which is present in the foot. Then you see at the posterior crease as well. When posteriorly on a normal foot, there are multiple creases present. It could be usually with the CTEV we see is a single predominant crease which is present as well. And at times this single predominant crease may be rigid as well, which is actually present along with the Equinus. Then you have to feel the lateral part of the head of the talus. Why we are feeling the head of the part of the talus? Because the head is going this way and going downwards. When this goes like this, the posterior aspect of the dome of the talus actually goes laterally and protrudes outward, and that can be felt along with the talocalcaneum joint. And this both the parts, the calcaneum as well as the talus, are palpable on the lateral, superior lateral aspect of the foot, and they has to be palpated how much they are palpable. If they're palpable, it's good. If they're somewhat palpable between this talocalcaneal junction, there is mild gap, this probably some degree of problem is there. If you cannot feel the head of the calcaneum talus as each other are different from each other, as you feel only a single head over there, it could be calcaneum, it could be talus, this means this is actually deformity is more aggressive, it's more rigid. and other is you feel the heel, that is you feel the calcaneum. Why you have to feel the calcaneum? Because how much tough it is. If it is easily felt, you can feel it, that's very good. If you cannot feel it, this means this is more rigid deformity, because calcaneum has not actually developed from a cartilage into bone. Now we give points. How do we give points? First I will be explaining how we give points, and then I will be explaining what are the other 4 components which have been added to this Pirani score when the modified Pirani score has actually been now devised. What is, if it's easily I said when it goes into dorsiflexion, this means it's very supple, you give it 0. But if it's going up till neutral, you give it 0.5. And if it's not moving at all, it's very rigid, you give us 1 point. Then comes the curvature of the lateral border. If it's completely correctable, when you push the toes back to the midline, that is 0 points. Partially correctable, you give it 0.5. And if it's not correctable at all, it means 1 point. Then comes the medial creases for the cavus of the foot. If it's you lift the head up of the first metatarsal and gets completely correctable, this means it is 0 points. And if it's partially correctable, it means 0.5. And if it's completely correctable, this is not correctable at all, and you see a very rigid crease, that means it's actually 1 point. Then comes the posterior crease. Normally, a normal foot, you will say, if you see multiple creases, this means it's 0 points. If you see 2 to 3 creases, or 1 rigid crease and 2 to 3 creases along with it, then probably it's 0.5. And if you see a single large crease which is actually very rigid, this means it is 1 point. Then you feel the lateral part. If it is easily, there is actually a junction between the talocalcaneal gap. If that gap is completely reduced and you cannot feel it, this means it's 0. If it's partially reduced during the maneuver when you're correcting the varus and equinus of the hind foot, this means it's actually 0.5. And if it's not reducible at all, this means it's 1, because it's fixed in subluxation, and that means that the talus has hinged over the calcaneum in a more rigid fashion. Then you have to feel the heel. Why we have to feel the calcaneum tuberosity is palpable or not? If it's palpable like a bone, and how do we assess it? For example, the best way is to you touch your chin. This is how hard it is. If this is what you feel, this means it's 0. If you touch your nose and you can feel this slightly soft as compared to if your feeling is like you are touching a part of your nose, this means it's 0.5. And if you are touching your earlobe, if that's soft and you cannot feel any bone at all, this means it's quite cartilaginous at this moment, and probably it's not palpable at all, and that is it's 1 point. This was the Pirani scoring system. Now then it was later on modified. For example, when we are dealing with the medial crease, along with the medial crease, we also started measuring between the talonavicular gap as well, because the problem was at the talocalcaneonavicular joint. Talonavicular as well as the talocalcaneal joint, both were involved. We started measuring the gap as well, though this one thing was added. When we are going posteriorly, we had to check the rigidity, the equinus, the crease. Then we had to check as well as the heel we have to feel the heel. Along with that, we also started measuring the talofibular gap. That is, the talus and fibular gap is how much. If there is no gap, this is 1 point. Mildly palpable, this is 0.5. If there is completely palpable gap, this means it's 0 points. Then from when we went on to the lateral border, along with only 2 things were mainly measured. That is, we have already discussed the curvature of the lateral border and the lateral part of the head of the talus. But along with this, we went on to the forefoot as well, because the forefoot is also in adduction. Therefore, we have to check how much adductus of the forefoot can be corrected. Can it be brought to more than 90 degree? For example, if it's like this, and this is the 90 degree axis, can it be brought to 90 degree or beyond 90 degree? If it goes beyond 90 degree, that is 0 points. If it's brought till 90 degree, it's 0.5. And if it cannot be brought at all, this means it is 1 point. This was the third thing which was added in the modified Pirani. And the fourth thing which was added was basically bring the toes up, you dorsiflex the toes only. Why we are dorsiflexing the toes? Because it's not isolatedly bony problem. There is also associated with the intrinsic muscle contractures as well. For example, adductus is caused by the contractures or tightness of the intrinsics as well as FHL and FDL. The cavus is caused by the tightness of tibialis posterior, and the equinus and varus of the hind foot is actually accompanied by the tightness of tendon Achilles as well. So we are also measuring the muscles. Therefore, if the forefoot or the toes can be dorsiflexed less than 90, it is actually 0.5. If they cannot be dorsiflexed at all, this means intrinsic muscles are very tight, that is 1 point. And if they can completely be dorsiflexed more than 90 degrees, that is they are very flexible, there is no tightness of the muscle, so the point is 0. So initially Pirani was calculated out of 6, but now we have 0, 0.5 and 1, so maximum could be 1 for all the 10 criteria which has been included in the modified Pirani. So maximum score could be 10 and minimum score could be 0 in the case of the Pirani, and we calculate how much deformity is present. If a score comes out to be 8.5, let's suppose, and in another foot it comes out to be 4.5, this means the 8.5 foot is more rigid. It will be laterally more difficult to treat this foot conservatively as compared to the for that 4.5 foot. But that does not mean, this problem with this Pirani score is it does not give us a cutoff value from where we have to move towards conservative treatment or operative treatment. Therefore it gives us an assessment of how difficult it would be, how rigid the foot is, and how rigid and severe the deformity is, but it does not give us exact cutoff from where we have to proceed directly to the operative treatment or we have to continue with the conservative treatment.